Good morning, all. Myself, Dr. Naveen Mohan, Associate Professor and HOD of Emergency Medicine at AIMS Kochi. This one is going to be a PG level discussion of acute management of stroke in the emergency department. These are the headings under which I'll be dealing the topic: definition, types of stroke, blood supply of the brain, acute stroke DDs, goals in stroke care, primary survey, which comprises of the ABCDE approach, secondary survey comprising of ample and neurological examination, a word regarding the clinical features of stroke, how to recognize stroke in ER using these scoring systems, imaging modalities, CT as well as MRI, and also a word regarding the interim management of stroke in the emergency department. So what is basically stroke? An acute stroke is defined as abrupt onset of any neurological deficit that is attributable to a focal vascular cause. And there are basically two types of stroke. One is ischemic stroke, the other one is hemorrhagic stroke. Majority of the strokes are ischemic stroke. 85% of the strokes are ischemic stroke. And only 15% of the strokes are hemorrhagic strokes. Ischemic stroke happens because of lack of blood flow to the brain because of some occlusion, right? And hemorrhagic stroke happens because of rupture of the blood vessels, usually due to reasons like hypertension, AV malformation, bleeding disorders, platelet disorders, aneurysm rupture, or even trauma. So let it be ischemic or hemorrhagic, both cause parts of the brain to stop functioning properly. So what are the two types of ischemic stroke? In this session, I'll be dealing more with ischemic stroke. Okay. So what are the two types of ischemic stroke? One is thrombotic, and then comes the embolic. Thrombotic means there is an obstruction caused by an atheromatous plaque formed in one of the blood vessels supplying the brain. Effectively, what happens is the blood supply to the brain parenchyma gets decreased and ischemia happens, and permanent brain damage. In case of embolic, what happens is the thrombus sitting somewhere else far away from the brain, for example, the cardiac chamber or the carotid artery or the aorta, may dislodge, form an embolus inside the circulation, and finally goes to the cerebral circulation and occludes the cerebral circulation. And that also causes abrupt cessation of blood flow to the brain and ultimately brain damage. So in this diagram, you can see this is the brain tissue. This is the MCA territory. The brain tissue receiving little or no blood flow is known as the ischemic core. Just look at the diagram here. And is made up of cells that die rapidly. And usually 1.9 million neurons are lost for every minute that a stroke goes undetected. And surrounding this ischemic core, we have got the ischemic penumbra. And this is the tissue that is hypoperfused, functionally impaired, and at risk of infarction, electrically inexcitable, but a salvageable area. So if you perfuse it at the right time, this penumbra can be saved. So the longer the penumbral tissue, that is this area of the brain tissue, remains untreated, the greater is the chance of undergoing infarction. And symptoms often evolve over hours and may worsen or improve depending on the fate of the ischemic penumbra. So your primary idea is to save this ischemic penumbra from going into permanent damage. And that is possible only if the patient presents to the emergency department within 4.5 hours after onset of symptoms. So that is the golden time. In the pre-hospital setting, this is what the paramedics need to know. Face the fast examination, fast. Face, if there is a deviation of the angle of the mouth, or if there is a problem in the face, or if you ask the patient to do like that, and if one hand falls down, if they can't elevate both arms together, one hand falls down, or if there is a problem in the speech, then it indirectly means that patient will be having a stroke, and it's better to visit the emergency department at the earliest so that early revascularization is done. So this is advocated by most of the major agencies like American ASA And on a regular basis, we keep teaching the public also regarding the fast examination. And paramedics hopefully will also know about the fast examination. A quick overview about the blood circulation of the brain parenchyma, the cerebellum, as well as the brain stem. So you can just go through the diagram here. This is the arch of the aorta. Here comes the left subclavian artery. Here is the right subclavian artery. Here comes the common carotid artery, which goes up all along up, and then gets divided into the external carotid artery, which supplies face, anterior part of the neck, head, and all, and also the internal carotid artery. This internal carotid artery goes up and reaches the base of the brain, where it gets divided into the middle cerebral artery as well as the anterior cerebral artery. And it gives branches which ramifies all throughout the brain parenchyma. So this middle cerebral artery as well as the anterior cerebral artery, which arises from the internal carotid artery, is called the anterior circulation, and that supplies the anterior 3/5 of the cerebrum. So this is the anterior circulation. And there is something called as the posterior circulation also. Here, from the subclavian artery, you can see the vertebral artery going all along either sides of the vertebra. This is the left vertebral artery, this is the right vertebral artery. Both of them ultimately goes and joins to form the basilar artery here. The diagram on the left-hand side is an enlarged version of this area. This is also called the circle of Willis. Okay, so the vertebral artery goes from either sides, joins, forms the basilar artery, and ultimately the basilar artery divides and forms the posterior cerebral artery. So this is called the posterior circulation. And there are communicating arteries between the anterior circulation and the posterior circulation. This is the posterior communicating artery. So the posterior circulation supplies the posterior 2/5 of the cerebrum, as well as the brainstem and also the cerebellum. So if suppose something happens, if there is some blockage in the posterior circulation, naturally blood supply to the cerebellum or the brainstem or the occipital lobe of the brain will be affected. So the anterior circulation supplies mainly the frontal lobe, parietal lobe, and part of the temporal lobe. And posterior circulation supplies the brainstem, cerebellum, and part of the occipital lobe and part of the temporal lobe. So the vascular territory affected will determine the exact symptoms and the clinical behavior of the patient. So this one is another cross-section of the blood, showing the blood supply of the brain. This is the coronal section at the level of the caudate nucleus, internal capsule, and all. So this area is supplied by the anterior cerebral artery, this one by the middle cerebral artery, this one by the posterior cerebral artery. This is the coronal section. If you look from the lateral side, this is the ACA territory, this is the MCA territory, this is the PCA territory. From the medial side, this is the ACA territory, MCA territory, and the PCA territory. So depending on which blood vessel is affected, that corresponding brain territory will be affected, and the patient will have corresponding deficits. So you can just go through this area. What you're seeing here is the middle cerebral artery. Middle cerebral artery is giving some perforating arteries to this area, which supplies the internal capsule, the caudate nucleus above. Beneath is the thalamus, then the putamen, globus pallidus. Here is the sylvian fissure. And the problem with this area is that there is no collateral circulation. So if at all a small block happens somewhere here, this part gets infarcted very early. So what are the stroke differential diagnosis? We have got the stroke mimics as well as the stroke chameleons. Stroke mimics means you think it is a stroke, but it is not generally a stroke. Stroke chameleons means you think it is not a stroke, but it is actually a stroke. Okay. So these are the differential diagnoses. The most deadliest one is aortic arch dissection, which should never be missed in the ED. Patient may have chest pain also. severe chest pain associated with the left-sided hemiplegia. Then comes head trauma. If there is an IC bleed, naturally the other part of the body will be affected. And then comes hemiplegic migraine. If the patient has got a migraine, associated with that, he develops a hemiplegia, but the patient has got a history, or a history of aura is there, then it is more suggestive of a migraine. And if the patient had a seizure episode, and now the patient is unable to move his limbs, it is suggestive of a Todd's paralysis. Then comes the CNS tumor or abscess, which should never be missed in the ED, and which can be picked only in imaging. Then comes less common causes like cerebral venous thrombosis, functional deficit conversion reaction, hypertensive encephalopathy, MELAS, multiple sclerosis, GBS, spinal cord disorder, compressive myelopathy, subdural hematoma, in which the patient will have past history of head trauma, syncope, systemic infection, even patient with sepsis will have septic encephalopathy, which has to be ruled out after sending out the labs to look for the CBC-CRP. And then toxic metabolic disturbance such as hypoglycemia. This is very important because even in the primary survey itself, you'll be checking the GRBS and ruling out hypoglycemia. And also some exogenous drug intoxication, some sedative hypnotics and all, may cause a decreased sensorium, and you may think it is a stroke. Then comes hypokalemic periodic paralysis. In the ABG, you'll be able to pick it out very early in the primary survey itself. If potassium is low, patient may have features of hypokalemic periodic paralysis. Then comes transient global amnesia. Then viral encephalitis, usually herpes simplex encephalitis, Wernicke's encephalopathy. And another thing you may miss in the ED is the LMN facial palsy. Should be able to differentiate between LMN and UMN facial palsy. UMN facial palsy is seen in stroke, not LMN facial palsy. And then comes BPPV. Often patient comes with complaints of vertigo, and you may think it is a BPPV, but actually it's a posterior circulation stroke. And for that, you need to do a Hinds examination. I'll be dealing with that later. And then comes delirium. At times, patients with stroke can also present with delirium. And then comes a very deadly thing, which is called as a carotid artery dissection, and the vertebral artery dissection, which may also cause a stroke. So the ones marked in red should never be forgotten. So now the time benchmarks for potential thrombolysis. The current US guidelines recommend the following ambitious time benchmarks. Door to physician time, what they advocate is 10 minutes. Door to stroke team is 15 minutes. Door to CT initiation is 25 minutes. Door to CT interpretation, 45 minutes. Door to drug, 60 minutes. Door to stroke unit, 3 hours. So if you look at it, you can understand that we have got only 5 minutes for the complete, because door to physician is 10 minutes. Within 15 minutes, you'll have to inform the stroke team also. Within 5 minutes, you'll have to take a complete quick history and then do a quick examination, reach a diagnosis of suspected stroke, and then inform the stroke team. Okay, because time is brain, and every minute you wait, brain gets damaged forever. So the goals in stroke care will be a restoration of blood perfusion to reduce the effects of the primary insult. That means the primary insult which has happened to the ischemic core, and to prevent secondary brain injury, that is by reperfusing the ischemic penumbra. And also effective stroke care is multidisciplinary, which involves the emergency physician, the stroke team, the radiology, and the stroke unit. Now the other thing to be borne in mind is regarding the treatment. We have got, basically, broadly speaking, we have got 2 treatments, thrombolysis and endovascular thrombectomy for stroke. If the patient presents to the emergency department within 4.5 hours of symptom onset, he may benefit from the administration of thrombolytic agent, which is the RTPA, alteplase. Whereas, if he presents to the ED within 24 hours of symptom onset, endovascular thrombectomy is the option. So for that, the patient should therefore have a focused medical history, including exact time of onset of symptoms, and be urgently assessed for the inclusion and exclusion criteria of stroke thrombolysis. So the emergency physician should have a high sensitivity in picking up the diagnosis of stroke, and also he should keep a very low threshold for imaging. because once missed, it's missed forever. So then I'll briefly go through the ABCDE approach. So this is the way that you should be dealing with all emergency cases, let it be stroke or MI or whatever the case is. This is the step-by-step approach in which you should be dealing with the patient arriving at the emergency department. First of all, it is the airway and breathing. A patient with decreased consciousness or bulbar dysfunction because of a brain stem stroke may be unable to protect their airway. So in that case, you'll have to do intubation. And in patients with increased intracranial pressure due to hemorrhage, vertebrobasilar ischemia or bihemispheric ischemia can present with vomiting, decreased respiratory drive, or muscular airway obstruction. Ultimately, what happens is hypoventilation happens with the resulting increase in the level of carbon dioxide in your blood, and that may lead to cerebral vasodilatation, and ultimately it leads to elevated intracranial pressure. In that case also, you may have to intubate. So the idea behind intubation is to restore adequate ventilation and to protect the airway from aspiration. For intubation purposes, generally what we prefer in our ED is etombidate and thiopental. And always, while intubating, do a gentle intubation. Do not cause much of a stress to the patient, because that itself can cause raised ICP. And always, after intubation, when you tie to the neck, always avoid a neck tie. And patients with adequate ventilation should have the oxygen saturation monitored, and usually it should be between 94 to 98%. So patients who are hypoxic may have aspirated, maybe like it's aspiration pneumonia on top of a stroke, and they should receive supplemental oxygen to maintain oxygen saturation more than 94%. And always keep these patients nil per oral. The thing is, you don't know whether it's basically a ischemic stroke or a hemorrhagic stroke. If it is a hemorrhagic stroke and there is an indication for surgery, it's better to keep them NPO in the ABCD approach itself. Then moving on to circulation, connect all the monitors, check for the heart rate, see if bradycardia is there or not. Bradycardia suggests that the patient may be having a raised ICP. BP, look for BP. If there is hypotension or hypertension, hypertension may suggest a raised ICP. Hypotension may be due to other causes, like sepsis or even ACS may be there. Then CRT to look for shock, check for the heart sounds, take an ECG, rule out the precipitating causes such as atrial fibrillation, see if there is an associated MI is there or not. And in case of SAH, you may get a deep inverted T waves, which is also called the cerebral T waves. And also, the NICE guidelines advocate cardiac monitoring for the next 24 hours in all cases of stroke. 2 IV cannulas have to be placed and blood samples have to be drawn. Should always check the GRBS. If it is a hypoglycemia, correct it then and there itself, because it may not be really a stroke. It may be hypoglycemic coma. Okay. Then always check for ABG, look for creatinine. If there is raised creatinine with metabolic acidosis, uremia, it may be a uremic encephalopathy, and you may be thinking it is a stroke. Then comes lactate. If lactate is really elevated, it may be because of sepsis, septic shock, or it may be because of a recent episode of seizure. If lactate is in the range of around 15 to 20, and it may be a recent episode of seizure, and patient may be in TOTS paralysis. Then comes PaCO2. If the PaCO2 is really high, patient may be drowsy, and you may think it is a stroke, because it is type 2 respiratory failure, right? And then send blood samples for all the hematology, biochemistry, because hematology means APTT, PTNR will be required. If at all you are planning for thrombolysis, you need all these things. Biochemistry, look for features of any infection, CBC, CRP, and sodium levels. If there is hyponatremia, patient may be decreased in sodium, and that has to be treated first. And if at all poisoning is suspected, always send a toxicology sample also. And always avoid necklines if there is suspicion of raised ICP. Necklines can cause raised ICP. And usually patients will be dehydrated following a stroke. And maybe the patient was on the floor all night or may have swallowing difficulties. So as per the research, what they have found out is poorer outcomes occur if systolic BP is less than 100 or the diastolic is less than 70. So in such cases, hydration should be assessed, and hypovolemia should be treated with fluid boluses of around 250 to 500 ml normal saline. The ultimate aim is euvolemia. Now, the other causes of hypertension, such as sepsis or acute MI, should also be considered. Moving on to disability, GRBS should be kept between 140 to 180 milligram per deciliter as per the ASA and the ESI guidelines. GCS should be checked for any deterioration, because at times patient may have to be taken up for surgery also. Look for pupil asymmetry for raised ICP. If there is an IC bleed, patient may have a pupil asymmetry. Look for other lateralizing signs. Always address pain, nausea, vomiting at all levels. Whenever the patient says he has got pain or anything, always address. Never ignore that aspect of patient treatment. In exposure, look for temperature. Pyrexia after stroke onset is associated with an increase in morbidity and mortality. And no trial has been done to show whether treating the fever improves outcome or not. But it seems reasonable to give antipyretics and look for signs of infection such as UTI. And this is the position that the patient should be kept in. Keep the head in neutral alignment with the body. And head end should be elevated to 30 degrees. And along with that, look for any other sources of bleeding or evidence of trauma or any pills in the pocket. Because head trauma itself can cause features suggestive of a stroke. And if there is any pill in the pocket, which is like drug overdose, can also mimic a stroke. So this is how you should be going in a step-by-step manner in any suspected case of stroke. Otherwise, the thing is, you'll be having a tunnel vision. You'll be thinking solely about stroke. Other things will be missed in your when you start treating. So moving on to the secondary survey, always follow the pattern ample and systemic examination. Ask if the patient has got any allergies or not, medications. See if the patient is on any OHA, insulin, anti-epileptic drugs, OCP, drug overdose. If the patient is on amphetamine, cocaine, because amphetamine, cocaine can cause IC bleed. If the patient is having some anticoagulant use, and the time of the last dose. This is very important. If the patient is on some OHA or insulin, it means that patient may be having hypoglycemia. If the patient was on some anti-epileptic drugs, it may mean that patient has a drug defaulter and may have thrown seizure. OCP increases the chance of ischemic stroke. Now moving on to the past illness. These are the things which will have done. Whether the patient had a history of diabetes, hypertension, dyslipidemia. These are all stroke-causing, predisposing factors for stroke. And then the underlying neurological illness. If the patient is already having a stroke, it will be difficult to diagnose a new stroke. Okay. And whether the patient has got a history of TIA. If any patient having a history of TIA will usually have a ischemic stroke, thrombotic stroke. Then ask about whether the history of cerebral amyloid angiopathy is there or not. If that is there, it suggests mostly IC bleed. Whether the patient is a CAD, on aspirin, whether the patient has got any valvular heart diseases, whether he is already on some oral anticoagulants, if the patient has got some dilated cardiomyopathy, ASD, a patent foramen ovale. Because patent foramen ovale, you can get paradoxical embolism, wherein the embolus will be coming from the vein to the artery and then to the brain. Then ask if the patient has got any prosthetic heart valves, pacemaker, AICD, features of any infective endocarditis, because pacemaker, AICD, and all these things are not compatible with MRI. Because that is the next investigation that you are going to do if CT is not an option. Then comes history regarding DVT, other prothrombotic states, history of any recent trauma, bleeding diathesis, hypercoagulable states such as protein CS deficiency, antithrombin 3 deficiency. If there is any malignancy, ask if there is history of sickle cell anemia, which can occlude the blood vessel causing thrombotic stroke, vasculitis, pregnancy, psychiatric illness. At times, the patient may be having a functional problem, and you may think it is a stroke. So ask if it is having some psychiatric illness or not. When was the last meal? See when the last solid was taken and liquid was taken, because at times patient may be taken up for surgery and you need to know the time. Otherwise, it will become a contraindication. Then moving on to the events relating to the current symptom. This is the detailed history that should be taken related to the current symptom. When was the patient last seen to be normal? A detailed description of the event, including the onset time, should be taken. What was the patient doing at the onset or prior to the symptom? What is the course and progression? Was it abrupt, sudden, gradual, or a stuttering progression with periods of improvement? Any other associated symptoms? And specific questions should be asked on sentinel headache, onset headache, vomiting, LOC. Associated infection is there or not, or any other embolic sources. History of alcohol and smoking, because high chances of ischemic stroke in smokers. Ask if there is any family history of CVA or SAH, because that itself, if the family history of SAH is there, it is very high chances the patient may be having an SAH. Ask for ethnicity, PCKD, polycystic kidney disease, high chance for IC bleed, whether the history of hysteria is there or not. And the other thing you'll have to ask is specific questions to evaluate the contraindications for thrombolysis. So these are the things which comes in the contraindications for thrombolysis, whether ischemic stroke or severe head trauma was there in the previous 3 months or not, whether there was a previous intracranial hemorrhage, whether there is an intraaxial intracranial neoplasm, whether there is a GI malignancy, GI hemorrhage in the previous 21 days, whether there is intracranial or intraspinal surgery within the prior 3 months. So these are all specific questions to evaluate the contraindications of thrombolysis. So how to differentiate between strokes based on the clinical course? In ischemic thrombotic strokes, what happens is there will be a stuttering progression with periods of improvement. And patient may have a history of TIA, and males are more commonly affected. And on examination, patient may have a neck bruit. On the other hand, in embolic stroke, it will be a sudden onset with deficit maximal at the onset, and clinical findings may improve quickly. And usually the patient will have history of heart disease, such as valvular atrial fibrillation or even endocarditis. And ischemic, the embolic strokes usually get precipitated when the patient gets up at night to urinate or even after sudden coughing or sneezing. In case of intracerebral hemorrhage, subarachnoid hemorrhage, these are the hemorrhagic strokes. Okay. In intracerebral hemorrhage, it will be gradual onset and progression during minutes or hours in most patients. And patient may be having a history of hypertension, bleeding diathesis, maybe he is using some amphetamines, cocaine as illicit drugs, maybe some vascular malformations are there. And usually it is precipitated by sex or other physical activity. And patients will have a reduced alertness also. This is about intracerebral hemorrhage. On the other hand, subarachnoid hemorrhage means patient will complain of an abrupt onset of sudden severe headache, a thunderclap headache. And a focal brain dysfunction is less common than with other types. Patient may, just like intracerebral hemorrhage, patient may have a history of smoking, hypertension, a history of PCKD may be there, a family history of SAH may be there, and patient may be on cocaine and all. And usually it is precipitated during activity. So let's quickly move on to the clinical features of stroke. So these are the complaints with which usually patients come to the emergency department. Limb weakness, ataxia, paresthesia, impaired sensations, alexia, amnesia, agnosia, aphasia, constructional dyspraxia, apraxia, all these cranial nerve palsies, Horner syndrome, dysphagia, hoarseness, vision loss, diplopia, visual neglect, gaze palsy, hearing impairment, tinnitus, loss of taste, altered alertness, behavior, memory, hallucinations, vertigo, dizziness, facial pain, hiccups, headache, vomiting, nausea, LOC, seizure. So all these are the different symptoms with which a patient may present to the emergency department. But for a paramedic level, I think a fast examination is sufficient enough to know whether the patient has got a stroke or not. So the other specific examination will be assessment for vascular bruit in the neck and retroorbital regions, because ICS stenosis can also cause retroorbital vascular bruit. And should palpate the pulses in the neck, arms, and legs to assess for their absence, asymmetry, or irregular rate, rule out an aortic dissection. Then auscultate for murmurs, skin for signs of endocarditis, cholesterol emboli, purpura. Fundus should be examined for papilledema, cholesterol emboli. Head should be looked for signs of trauma and neck stiffness, because in subarachnoid hemorrhage, neck stiffness will be there. A tongue laceration may suggest a seizure. And if there is a report or suspicion of a fall, the neck should be immobilized until C-spine is cleared. Then comes examination of the extremities to look for evidence of systemic arterial emboli, distal ischemia, cellulitis, DVT. All these things should raise the possibility that the patient may be having an anticoagulant treatment. Suppose you're not getting these things in the history. Okay. Then comes the neurologic evaluation. The vascular territory affected will determine the exact symptoms and clinical behavior of the lesion. So in this diagram, you can see, this is the circle of Willis. This is the anterior cerebral artery. So if I occlude the anterior cerebral artery somewhere here, naturally the blood supply to the left-hand side will be the ACA territory and the left hemisphere will be gone. And patient will have, clinically, if you look at it, patient will have contralateral leg weakness. The leg weakness will be more than the hand weakness. And also executive dysfunction and abulia. Whereas if I occlude the middle cerebral artery here, suppose the right MCA territory is ischemic, then the patient will have a left-sided weakness. The opposite side weakness will be there, and left-sided neglect will be there, and gaze will be towards the right side. Similarly, here also, left MCA also. And in PCA syndrome, patient will have a contralateral. If I occlude the PCA here, patient will have contralateral hemianopia, confusion, amnesia, often with or without disorders of consciousness. And if I occlude the pica, which supplies the cerebellum, which patient will have a cerebellar stroke, and the patient will have symptoms of nausea, vertigo, tinnitus, imbalance, ipsilateral ataxia. And if the occlusion is somewhere in the mid-basilar area, patient will be in a locked state, and crossed symptoms will be the crossed sensory symptoms, and even ocular palsies. As we all know, this area supplies the posterior circulation supplies the cerebellum and the brainstem naturally. When there is some problem in the posterior circulation, the blood supply to the cerebellum and the brainstem will be gone, and symptoms will be present in a similar fashion. If the top of the basilar or thalamic perforators is occluded, there will be acute disorders of consciousness or even coma. So this I've already mentioned. The one thing to be differentiated is between a patient who comes to vertigo, you diagnose it as BPPV, and ultimately it turns out to be stroke. So then you'll have to do the HINS examination. If there is even one focal neurological finding and the HINS examination suggestive of a central vestibular dysfunction, that means if there is a normal head impulse test, direction changing nystagmus or skew deviation, it is an indication of urgent neuroimaging. So having said and done, there are so many varieties, clinical features of stroke. It's very hard to diagnose it within 5 minutes. For ER purpose, it's better to use a scale which is called as the Rosier stroke scale. In the emergency room, recognition of stroke in the emergency room, which comprises of only few parameters. One is there a new acute onset of asymmetrical facial weakness, or asymmetrical arm weakness, or asymmetrical leg weakness, or speech disturbance, or a visual field defect? For each one, you give 1 point each. Whereas if there has been a LOC or syncope, you give -1. If there has been any seizure activity, you give -1. Total score is between -2 to +5. If the score is more than 0, it means that stroke is likely. If the score is less than 0, it means that stroke is unlikely, but it is not completely excluded. So for an emergency physician, always make sure that you maintain a very low threshold for imaging in any case of suspected stroke. So this is about the NIH's National Institutes of Health stroke scale, which has to be done before imaging, and it is one of the most widely used and validated scale recommended for all patients with suspected stroke. And that is to determine the severity of a stroke and to predict the clinical outcomes. And NIHSS is used in the thrombolysis protocols to provide an objective baseline assessment of the neurological deficit against which improvement or deterioration can be judged. And it is composed of 11 items, adding up to a total score of 0 to 42. Score of less than 5 means mild, 5 to 9 means moderate stroke, 10 or more means severe stroke. So increasing scores has been shown to correlate with the size of the infarction on both CT as well as MRI. Usually a score of 4 or less generally have favorable clinical outcomes and a high likelihood that patient will be functionally independent. And many guidelines say that administering alteplase, the thrombolysis in the patients with high NHSS score more than 22 is associated with increased risk of hemorrhagic conversion. Then moving on to imaging, when to do a CT brain plane. CT brain plane is the gold standard for imaging in acute stroke. As per the NICE pathway, these are the indications for doing a CT brain. Indications for thrombolysis or thrombectomy, if patient is on anticoagulant treatment, if there is a known bleeding tendency, if there is a depressed level of consciousness, that is GCS below 13, if there is an unexplained progressive or fluctuating symptom, if there is a papilledema, neck stiffness or fever, if there is severe headache at the onset of stroke symptoms. In all these cases, you do a CT brain plane and rule out a hemorrhagic stroke. So exclude intracranial hemorrhage, which would preclude thrombolysis. Then you look for any early features of ischemia, such as the MCA dense sign or anything. Then exclude other intracranial pathologies that may mimic a stroke, such as a tumor or even a glioblastoma multiforme. So this one shows the imaging of acute stroke. Here is the CT, here is the MRI. As quite evident, it's very easy to pick ischemic stroke in the MRI DWI sequence. It appears white here. For CT, it is much more difficult. It's usually difficult for a new doctor to diagnose stroke in CT, but here you can see a dense MCA sign. But definitely you can rule out hemorrhagic stroke in CT. So in this, what does this show? This one shows intracranial bleed. So this is hemorrhage. If you just go in your system, if you just go keep your cursor here, naturally it will show 65 to 95. If it shows 65 to 95 Hounsfield unit, it means that it is a bleed. Whereas for bone, it is plus 1000 Hounsfield unit. So if you see something white here, just go towards that, see if it is the Hounsfield unit is between 65 to 95. It suggests a bleed. This is also a bleed on the left hemisphere. And the bleed is causing surrounding periorbital, surrounding edema, cerebral edema, as well as a midline shift to the right side. And what you're seeing here is a effacement of the sulci gyri. You can see all blood circulating into the sulci gyri. This is suggestive of and also the cisterns also. This is suggestive of a subarachnoid hemorrhage. So white in CT means bleed. What you're seeing here is a crescent-shaped white area in the CT, which is subdural hematoma. And this one, you may mistake it for a IC bleed, but it is actually a tumor. And this one is a glioblastoma multiforme. So these are the hyperacute findings in CT in case of an acute stroke. If the MCA territory is involved, you may get a dense MCA sign. That is actually a visualization of the clot directly, and it will appear at a very early stage. It is almost as early as immediate it will appear. And then after 1 hour, you may get some early parenchymal changes wherein there will be some loss of gray matter, white matter differentiation, and some features of cerebral edema, hypodensity of the cortex and all. So this is a much more clearer view. This is a dense MCA sign. Usually the flowing blood will be around 40 Hounsfield unit. And acute thrombus is not much denser, but as time goes on, the clot contracts and becomes hyperdense. It will be around 100 Hounsfield units. But if you keep it here, it will be 100 Hounsfield unit. And it suggests a clot. It is more pronounced in embolic strokes because the thing is, in the heart, it is the clot is already there, and it is already contracted, and it is already hyperdense. So if the patient has had an embolic stroke, naturally, you will be seeing this thrombus here. So this is right M1 segment of MCA. What you're seeing here is the top of the basilar artery. There is a thrombus here. This is called the basilar artery dot sign. Basilar artery dot sign. And the same diagram. If I do a CT angio, you'll be seeing hyperenhancement of filling defect in the CT angio here. This is the dense MCA sign. Here it is a hyperenhancement of filling defect in this CT angio. For this basilar dot sign, there is a hyperenhancement of filling defect in the CT angio here. Then comes the MCA dot sign, also called the Sylvian-Fisher sign, the M2 segment. Here you can see a dot here, a dot here, a dot here. This is the Sylvian-Fisher. And that area is in the subcortical area, and the collateral blood supply is very less. So early ischemic changes will be seen. Here it is also MCA dense sign. And if you go one slice above this, and the axial cut, if you go one slice above, you'll be getting this picture, and this is the insula. And if you narrow down the window, you'll be seeing a loss of insular cortex hypodensity. And then this is called the insular ribbon sign. This refers to hypodensity and swelling of the insular cortex, very indicative and very subtle early CT sign of infarction in the territory of MCA. And this region is very sensitive to ischemia because it is furthest removed away from the collateral flow. So if thrombectomy might be indicated, perform a CT brain plane plus CT contrast angiography of the head and neck, because it hardly takes around 1 to 2 minutes. But if you go for MRI, it will take around 10 to 20 minutes, and as time progresses, it is that much of brain is getting damaged. So better you go for a CT brain plane with a CT contrast of the head and neck. And also you can add CT perfusion imaging or MRI equivalent if thrombectomy might be indicated beyond 6 hours of symptom onset. This is a MCA sign non-contrast CT. This is a CT angiography showing filling defect, and this is the perfusion. This is how the CT perfusion looks like. There is a perfusion abnormality here. So if you don't treat the stroke at the right time, what happens is as time progresses, this part will get, the MCA territory will get infarcted completely. And it will appear black like that. So MRI can also be used to exclude hemorrhage, to assess the degree of brain injury, and to identify the vascular lesion responsible for the ischemic deficit. DWI sequence in MRI is highly sensitive and specific in determining ischemia. So if you look at the MRI stroke protocol here, this is the DWI sequence. If there is white in DWI and if there is black in ADC. In ADC sequence, if it is black, it means that the stroke is acute onset. White in DWI, black in ADC. This one shows DWI sequence, stroke in the PCA territory. This is the ACA territory. This one is the MCA territory. Here it's the, by the timelines, ADC, DWI, T2 weighted image. Initially in DWI, if it is an acute stroke, it will be white. And then as time progresses, it will become black. Whereas in ADC, in the acute phase, it will be black. As time progresses, it becomes white. T2 weighted image, as time progresses, maybe after like 7 days to 30 days, it will become white, as per this diagram. So for an emergency physician, what you need to know is, look for the MRI stroke protocol, look at DWI if it is white and ADC is black. Take it as an acute ischemic stroke. Then MR angiography DWI with or without MR perfusion weighted imaging for patients who may be eligible for mechanical thrombectomy can be done. And this is one important thing. Suppose the patient had a wake-up stroke, or the patient had an unknown stroke onset time, and if you take an image, MRI, and if in the DWI, if it is white and black in flare sequence, it suggests that the stroke onset is within 4.5 hours, and then patient becomes eligible for intravenous thrombolysis. White in DWI, black in flare means that patient is eligible for intravenous thrombolysis. This is in the case if you're not able to get a reliable onset time. Then other adjunct investigations that can be done are echo, transesophageal echo or transthoracic echo, to look for basically LALV thrombus, vegetations, structural cardiac abnormalities. For 45 years and more, you prefer transthoracic echo. And with no identified disease in neurovascular imaging and with a high suspicion of LV thrombus, and if transesophageal echo is contraindicated. For all others, you do a transesophageal echo. That is usually done not in the ER, after admission only, in the stroke unit only, it will be done. Then moving on to the lab studies which has to be sent. As I've already mentioned, GRBS is important. The primary survey itself, you should be doing the GRBS and correcting it then and there itself. Then look for ECG for other underlying ACS in unconscious patient and for AF detection. Continuous cardiac monitoring is recommended. CBC, troponin, APTT, PTINR, clotting time, thrombin time, and other tests such as D-dimer, LFT, pregnancy tests as warranted. So let's move on to the immediate antithrombotic treatment of acute ischemic stroke. So any patient presenting with acute ischemic stroke, and if the patient is not on oral anticoagulant prior to the stroke onset, see if the patient is eligible for intravenous thrombolysis or a mechanical thrombectomy. If the patient is not eligible, you can go through this algorithm. You start an antiplatelet therapy as soon as possible using this NIHS scoring. You calculate the NIHS score. If the score is more than 5, NIHS is more than 5, start aspirin alone. Whereas if the score is 5 or less, you start on dual antiplatelet therapy. And later on, you can continue evaluation to determine the ischemic mechanism. Whereas if the patient is eligible for intravenous thrombolysis or mechanical thrombectomy, treat with either of them, and then withhold the antiplatelets and the anticoagulants for at least 24 hours. This is the guideline. For the next 24 hours, you withhold. And later on, if the stroke evaluation is completed, you can choose a long-term antithrombotic therapy, which is usually done in the stroke unit. If the stroke evaluation is not completed, then you can go through this pathway. You can start antiplatelet therapy according to the NIHSS score. So the other interim management in the AD includes blood pressure control in ischemic stroke. The thing is, if the patient is planned for thrombolysis, always reduce the BP to less than 185/110 and thrombolyze. If it is above that, do not thrombolyze. Always make it below 185/110. But if the patient is not planned for thrombolysis, then you should reduce the BP to less than 220, 120, because your idea is to save the ischemic penumbra. This much of BP is required to save the ischemic penumbra. That is the body's own mechanism to protect the ischemic penumbra, and you shouldn't be unwantedly reducing the BP so that it causes much more damage to the patient. So unwanted hypotension in a stroke case should be avoided. Then comes, these are the drugs which are used for reducing the BP. We have got labetalol, nicardipine, clevidipine, hydralazine, enalaprilat. Labetalol dose is 10 to 20 milligrams IV over 1 to 2 minutes and can be repeated one time. Or you can use a nicardipine, 5 mg per hour IV infusion, which has to be titrated every 5 to 15 minutes. Maximum of 15 mg per hour can be given. Then comes clevidipine, which we do not use here. After initiation of reperfusion therapy, your target BP should be less than 180, 105. And that should be controlled with labetalol IV infusion 2 to 8 mg per minute, or nicardipine 5 mg per hour infusion. And if still BP is not controlled, you can, or diastolic BP is more than 140, you can consider sodium nitroprusside. The thing is, monitoring is very important. Always monitor the BP every 15 minutes for the next 2 hours from the start of thrombolysis, then every 30 minutes for the next 6 hours. This is the case about acute ischemic stroke. And fluids, always avoid fluids containing glucose, which may exacerbate hyperglycemia. And also, blood sugars should be kept between 140 to 180. It is advocated by both the ASA as well as the European Stroke Initiative guidelines. Next comes the swallowing assessment, or assess swallowing function prior to administering oral medications or food, and always control temperature. So when to call the neurosurgery department? So if there is a cerebellar ICH 3 centimeter or more, or causing brainstem compression, or if there is an intraventricular hemorrhage with obstructive hydrocephalus and neurologic deterioration, or if there is a hemispheric intracranial hemorrhage with life-threatening brain compression or obstructive hydrocephalus. These are the indications which is mentioned in NICE guidelines as the indications to call a neurosurgery department. And always you reverse anticoagulation. If the patient is already on some warfarin, dabigatran, UFH, LMWH, or any factor Xa inhibitors, you reverse it. Warfarin, antidote to give is 4-factor prothrombin complex concentrate with IV vitamin K. Dabigatran is, as we all know, it is idarucizumab. Factor Xa inhibitors, 4-factor PCC and andexanet alpha. UFH, it is protamine sulfate. LMWH, andexanet alpha and protamine sulfate is also an alternative. And always use isotonic solutions for volume resuscitation and maintenance. Always maintain serum sodium more than 135. Repeat CT for neurologic deterioration or signs of elevated ICP. And if the patient is found to have SH, you should be giving nimodipine 60 mg given every 4th hourly to reduce the vasospasm. And osmotic therapy via central venous catheter is also advocated, usually the hypertonic saline or mannitol. Hypertonic saline should be given in order to maintain sodium between 145 to 155 milliequivalents per liter, and mannitol should be given in 0.25 to 1 gram per kg IV bolus every 6 hours. In case of BP control in hemorrhagic stroke, what I have mentioned previously is the ischemic stroke. For hemorrhagic stroke, it is a bit different. If the systolic BP is more than 220, rapid lowering of systolic BP to less than 220 is advocated. And thereafter, the blood pressure is gradually reduced over a period of hours. Ultimately, the target should be 140 to 160 millimeters of mercury. On the other hand, if the systolic BP of the patient is between 150 and 220, then the target of 140 millimeters mercury should be attained ideally within the first hour of presentation. These are according to the NICE guidelines for BP control in hemorrhagic stroke. So for most patients with an initial systolic BP of 160 millimeter mercury or more, usually we prefer nicardipine 5 mg per hour for initial treatment because it is fast acting and can be quickly titrated. And BP should be monitored every 5 minutes. And patients are monitored for at least 1 hourly to assess neurologic deterioration. And for patients with systolic BP less than 160, we usually start with labetalol 20 mg IV bolus every 10 minutes. For its ease of administration and long duration of effect. So these are the two options, labetalol and nicardipine. Regardless of whether it is ischemic stroke or hemorrhagic stroke, these are the two options. In summary, always address the ABCDE, always treat patients in a systematic fashion, because at times there are chances that you may miss other major diagnoses if you look at this patient only from a stroke point of view. Always identify stroke at the earliest, the emergency physicians should have a very high sensitivity for picking stroke, and always alert the stroke team within 5 minutes, immediate CT, plus or minus CT angio to differentiate between ischemic and hemorrhagic stroke and stroke mimics in consultation with the stroke team. And always plan for thrombolysis or thrombectomy if the patient presents within the window period and if all the indications are met, and always control and maintain the blood pressures, monitor the GCS and pupils at regular intervals. Thank you.